Alright guys, we are back and we are going to talk right now about inert tissue disorders, and just to let you know that this will be going over fractures as well as ligament issues and by nature of the elbow and its susceptibility to fractures, dislocations, things like that. There are some images in this lecture that are graphic, to say the least. So nothing terrible, nothing, grotesque, but just enough that might make you a little queasy. So as you're looking through this or whatever, just know that those may come, and I'm not going to give you any other warning outside of this. So as we get into this, we're going to learn about ligamentous injuries of the UCL, as well as elbow dislocation injuries. We'll talk about UCL is the medial side of the elbow. We'll also talk about the lateral side of the elbow, but truly elbow dislocation will also be joined in with the ligamentous injuries because it is an instability event. And then osseous injuries like fractures, and then we'll talk about chondral injuries, meaning cartilage defects or injuries like osteoarthritis and radiocapitellar chondromalacia or OCD lesions of the capitellum. So ligamentous, the big one here is the UCL, ulnar collateral ligament injury, also known as the medial collateral ligament, and also known as the medial ulnar collateral ligament. So all three of those are used interchangeably, but we typically will call it a UCL injury. And so with this, we'll also get into medial epicondyle apophysitis, and then eventually into elbow dislocation. So we get into the UCL ligament injury. This is the major stabilizer of the medial elbow, and it prevents valgus torque. And so there's three bands associated with the UCL. One is the anterior, another is the posterior, and another is the transverse. And I've put this picture on the right to give you guys a artist rendition of what these ligaments may look like in a flexed elbow. And you can see the anterior bundle runs from the medial epicondyle to what we call the sublime tubercle of the ulna, which is right here. And this is the primary bundle of the UCL that's injured with throwing or pitching, and which leads to what we know as Tommy John surgery. So a lot of you guys have heard that term, and we'll go into what that actually means today and in the postoperative lecture as well. So the UCL is, of course, the primary restraint for valgus torque, but bony anatomy does provide primary stability less than 20 degrees of elbow flexion and greater than 20 degrees of elbow flexion. So at the ranges, the mid-ranges is where the UCL will provide the most restraint and dynamic stability from 20 to 120 degrees of flexion, and this is where the arc of the throwing motion occurs. Essentials of diagnosis here. So if someone has injured this area, they'll have pain at the medial epicondyle or sublime tubercle, or in that general area. It's usually because of repetitive valgus overload with throwing and or trauma caused by valgus stress to the elbow, such as a Fuchs injury and hyperextension injuries. Considerations here is pain usually comes on more gradually over time. You can have a singular moment or a pop, but it's not as common as the slow chronic buildup and inability to throw without pain. And usually a lot of these individuals, we'll talk a lot about throwers with UCL injuries because that's where it occurs the most, and especially in baseball. And so what you'll hear most of these guys say is they've lost command or they lost velocity on their pitches, and then they start having elbow pain. So there you have it. So we move on here. This picture on the right is a guy named Steven Strasburg. He's a pitcher for the Washington Nationals. He is very well known because he was a #1 overall pick coming out of college, and he pretty much immediately in the major league sustained a UCL injury, had to get Tommy John surgery, and then later on got a revision surgery. He had two, and we won't go into why or what risk factors he has, but this is the amount of elbow torque he has on his shoulder. So you can see he has about 170 degrees of external rotation if you line that up with the axis of his torso, and just a lot of torque on the medial elbow, as you can see. So, and he throws very hard. He throws around 100 miles an hour. So anyways, Signs and symptoms of this of a UCL injury are medial elbow pain, pain during throwing, pain usually during the acceleration phase of throwing, pain, laxity, or gapping with valgus stress tests. That's usually more in your traumatic cases and or cases that are hyperextension injuries. May report a history of pop, numbness, and tingling into the hand just because of the proximity of the ulnar nerve. You may have concomitant ulnar neuritis with this. And functional implications here, you have difficulty with weight bearing, typically, course difficulty overhead throwing, and stiffness may be secondary to joint effusion, which may limit your ADLs. So the ulnar collateral ligament, I'll move my little face here. Differential diagnosis is going to be flexor pronator mass strain. So the flexor and pronator common tendon attaches into the medial epicondyle, and one of the hallmark dynamic restraints, or hallmark signs rather, of a UCL injury is chronic flexor pronator mass tightness or discomfort. And so what happens there is you have a redundant or attenuated UCL, and so your dynamic restraints, your flexor pronator mass tries to create dynamic stability in the absence of a functioning UCL. And so anyways, flexor pronator mass strain is a differential. You may, if they're skeletally immature, try to rule out medial epicondyle apophysitis, which is a growth plate related injury to the medial epicondyle. We'll talk about that later. You want to rule out a medial epicondyle avulsion fracture. You want to rule out valgus extension overload, which happens in the medial elbow but a little more posterior, and then ulnar neuritis, and of course medial epicondylalgia. Tests and measures here. The big tests are valgus stress tests at both 0 and 20 degrees, and when I'm there in clinic, been in clinic all day. So when I'm there in at class helping you guys, I'll show you the ways that I do this, and I'll have actually I already have recorded me doing these special tests on an individual, so that you guys will be able to see a recorded version of how I do the special test. But valgus stress test at 0 and 20 degrees. The moving valgus stress test, this was coined by O'Driscoll out of the Mayo Institute up here in Rochester, Minnesota. And basically you're trying to mimic the layback and valgus toward of a throwing motion, milking maneuver, and then direct palpation of the medial epicondyle or sublime tubercle. And the sublime tubercle is the distal attachment site of the UCL, not to be confused with sublime, the band that can't remember the name of that famous song, but anyways, Sublime. Yeah, you guys know that band. So, UCL injuries, how do we treat these? We attempt a conservative approach first. And so, let's just put this in the context of a baseball player. We have a baseball player who feels a pain in their medial elbow. They get an MRI. It says partial thickness, low-grade sprain of the UCL, which is fancy words of saying that this is a partial grade injury. Then we will try to rest and perform activity modification or restriction about 6 weeks. No throwing. In the meantime, we're going to increase range of motion of the shoulder. When they promote healing of the MCL, the UCL, the distal attachment site of the UCL has less propensity to heal because of blood flow issues. So if it's proximal sided tear, we have it's a little better prognosis. Of course, we're going to keep strengthening. A lot of times, these individuals have shoulder flexibility impairments, which lead to improper kinetic chain efficiency and thus more strain on the UCL during layback. There are some other factors that are pretty obvious as well, but that's for your sports class, in my opinion. So What do we do? Eventually, we try to get them back to throwing, and one of two things is going to happen. They're going to get better and do well, or they're not. And so if they don't, they may be a candidate for UCL repair with an internal brace or a UCL reconstruction, which is known as Tommy John surgery. And so the two big ones there is the UCL repair is just that. It's a repair, a direct repair of the UCL, and the UCL reconstruction is a, for lack of a better term, reconstruction of the UCL because of the extensiveness of the injury, or if it's a mid-substance injury. So a little bit of this like over your head, that's okay. Just know that there's surgical ways to repair the UCL or reconstruct the UCL, and we'll go over them in the post-op lecture as well. So if this injury happens in the youth athlete, this is known as little league elbow or medial epicondylar apophysitis. And this is exactly the same mechanism of injury as reported to be from 4 to 39% incidence in early adolescence. And usually these are 8 to 11-year-olds who throw too much. And it's because their growth plates at the medial epicondyle has not fused. And so instead of sustaining a UCL injury, at that age, the bone at the growth plate is weaker than the ligament. And so the stress that goes through the elbow is directed towards the growth plate because the ligament is more robust and stronger than the growth plate. So the path of least resistance at the growth plate, and that's where we'll start having issues. And so here are some risk factors for that. And honestly, a lot of these risk factors are similar for UCL injuries as well. So you can look at the high risk factors and the competition risk factors, pause it there and look over those. But a lot of it has to do with repetitive overuse, volume, and velocity, etc. So this picture on the left you'll see later on as well. What I want you to appreciate there is when you throw a ball, you'll have medial-sided valgus stress, which will in turn gap the elbow. And if that side, the medial side's gapping, the radial side, or the lateral side, whichever term you want to use, will compress. And so what you'll get is essentially where this black arrow is your UCL. And so that's going to gap open and put strain through the UCL. But these two bones, the radial head and the capitulum, will capitulum is this rounded portion of the distal humerus. It's where the radial head articulates with. The fovea of the radial head articulates with that. And so you'll get compression at the capitulum and a lateral shear force as well. If you see the growth plates of the elbow here, which is why I want to use this picture, but also because of the tensile and compressive forces here shown here. But if you injure this bad enough, you can sustain what's called an avulsion fracture of the medial epicondyle. And so that growth plate that's here will fracture. It's called Salter-Harris fracture. And what they have to do, if it's separated by 5 millimeters or more, that's an indication for surgery. Otherwise, they try to let it heal. They take a screw and they pin it back. You can see the growth plate here as well. And it looks like on a repeat x-ray, this individual, slightly different angle here of the elbow, but it looks like that growth plate may have fused later on. Anyways. What do we do to treat this? Well, discontinue aggravating activities. Very similar to UCL injury. Thoracic spine mobility, scapular stabilization, glenohumeral joint mobility, shoulder girdle flexibility, periscapular and cuff strengthening, and any non-painful elbow and forearm strengthening. So posterior shoulder is a very common area that's very tight. So we do a couple stretches like the sleeper stretch and the sideline cross-body stretch, and try to address any other impairments they may have. This chart is from a study by Ellen Shanley, who was one of my mentors during residency. It's a great chart to take you through the phases and progression of rehab for Little League or growth plate related issues regarding throwing, both Little League shoulder and Little League elbow. And so you can follow along here. It's just kind of a good chart to understand. So next, move into elbow dislocations. All right. So where do we start with elbow dislocations? Well, it's traumatic injury to the elbow. It's displacement of the ulna in the radius in a posterior, anterior, or lateral direction. It is usually caused by a forced hyperextension, and this is typically caused through the mechanism of axial loading, supination, and valgus stress. So if you supinate and you land on your arm, it goes through any sort of valgus stress, or if you're hypermobile, you may dislocate your elbow with enough force. And so if you look at the picture on the bottom right, you'll see there's 3 different essentially grades of elbow dislocation or instability. So the first one is obviously normal. Grade 1 is posterolateral rotary instability, PLRI. And so what you can see here is axial compression or weight bearing through the arm. You can see this kind of in unclear text, but it says valgus stress and then supination. Those 3 things in combination causes the radius to start shifting off the capitellum. With enough axial force, you'll get a posterior shift. And then a grade 3 is called perched, meaning it's not a full dislocation, but the coronoid process essentially gets stuck on the distal humerus. And then finally, a full dislocation is both the radius and the ulna are posteriorly dislocated with the same sort of mechanism of injury here. So it's another schematic here showing how supination will cause the radial head to have this posterior glide, and so with enough force, pop out backwards. All right, so here's some pictures, unfortunately, of some individuals who have sustained elbow dislocations. And football player, basketball player, soccer player, you can see that here, and of course Olympic weightlifter. And so, you know, these are all really terrible images. However, these are athletes that are putting their bodies through extreme situations. And so they're landing on their arms with high forces. They're large individuals. I feel bad for the soccer player because it seems like he landed and maybe the other guy's knee forced him into a valgus moment. And of course the weightlifter, this is just extreme amounts of weight. Not only is his elbow doomed, but I hope his back and neck and everything's okay as well. This is something like, I don't know, 400 pounds, maybe close to that. Don't know my kilos too well, but it looks like it's 150 kilos plus 10 on each side. So 170 kilos times 2.2 is going to put you in the range of 350 to 400. So tough to sustain that. So as we move on here, elbow dislocations warrant an immediate referral because of neurovascular compromise or the risk of neurovascular compromise from the dislocation. There's a lot of neurovascular structures within the elbow, and if you dislocate it, we really worry about something becoming injured. And so most common directions of posterior dislocation, and we do think that with most elbow dislocations you're going to have a ligamentous injury, but what's really remarkable is sometimes there's not. It's really weird. Get an MRI back that says reduced dislocation and ligaments intact, and you're going, oh, okay. Doesn't really make sense. But anyways, it's good to have the MRI and post-reduction films on that as well. So signs and symptoms, it's going to be a visual deformity, pre-reduction, severe pain, immediate swelling. Post-reduction, they're going to have gross effusion, reduced range of motion, decreased strength, decreased grip strength, potential laxity or pain in collateral ligaments, and pretty obvious what it looks like. It looks something like this, right? So the olecranon's posteriorly dislocated, and they can't move their arm very well. So differential diagnosis, because of the deformity and the bruising and stuff that's associated with it, you may want to rule out an elbow fracture, like an olecranon fracture or a distal humerus fracture. But really, it's not your job as a PT. Your job is to rehab them. But it's something to think about as an on-field injury. Main thing you want to understand is if something looks wrong like this with the elbow, they need to get to the emergency room as fast as they can. So tests and measures, there's really no special test for elbow dislocation because of the obvious nature of it. However, as we looked at those three types of grades, essentially, you have the 0, 1, 2, and 3. 0 is normal. 1 is the PLRI. That's posterolateral rotary instability. That would be a partial subluxation dislocation instability event. And what you can do is something called the push-off test. So you recreate the mechanism of injury of a supinated hand, weight-bearing position. So you just push down on your seat, try to lift yourself up, and there will be a video of that special test that you have access to. If that reproduces symptoms of pain, we consider that positive. So that's one test you could do if it's a subluxation. You could also use a tuning fork or vibration to see if it irritates the area to rule out a fracture. You also want to check their neurovascular status by doing like capillary refill tests, things like that, dermatomal screen as well. So there you have it. What do we do for interventions? Well, really once it's reduced, we try to progress them as tolerated. In the first 2 weeks is our acute inflammatory response to the injury, and so we're trying to manage those symptoms. Some range of motion limitations from pain, and as well as joint effusion. And so the picture on the top right is someone who's had an elbow dislocation who elbow became stiff following, and that's not uncommon. It's really hard to get elbow range of motion back after severe injury like this, whether it's a fracture or a dislocation. When the integrity of the joint is ruined temporarily, it's hard to put the pieces back together, so to speak. But some people can get their range of motion back quicker than others, and if they do, you can start working on strength and addressing any other inadequacies they may have. The picture at the bottom right is a picture of something called a dynasplint. So someone who has a stiff elbow like this, we'll get them into a long duration, low load stretching device like this, where they have this little dial that they can incrementally turn to stretch their elbow into extension for inducing creep into the tissues. So just some pictures for you guys to digest there. The next section we're going to be going over is osseous injuries and fractures. A little different section because there's so many different types of fractures, and so I just want to make sure that we're exposed to some of these. So first fracture is called a distal humerus fracture, and the two pictures on the left are what it looks like pre-surgery. Pictures on the right are what it looks like post-operative. So you can see they use plate and screws to reduce the fracture. And just to give you some update on elbow x-rays, there's three types. The three most common types are an AP view, so front to back view, a lateral view, and then finally you have an oblique view. And so that's not listed here, but you may see an oblique view as well. This is a medial epicondyle fracture. We talked about this with medial epicondylar apophysitis. So, and you can see how the medial epicondyle is avulsed and how a screw is there to place it back. Could have a radial head fracture, and a radial head fracture has three types. One, a closed fracture. Two, displaced fracture. Three, a comminuted fracture. And so if it's not bad, right? And this is also an intra-articular fracture as well, meaning it goes into the joint space, whereas this fracture here is a radial neck fracture, easier to fix because the cartilage and the integrity of the joint is not disrupted. But here's how they fix it: plate and screws again, or it's bad enough like a comminuted fracture, they'll do a radial head arthroplasty. So just replace that. Here's an Olecranon fracture. You can appreciate that on the x-ray here. And this is how it's fixed, plate and screws. You also have a coronoid fracture, which is the anterior portion of the ulna, the ulnar cup, if you will, the Olecranon fossa ridge, if you will, gets fractured. Plate and screws. That's how they do everything now, plate and screws. It's called a Monteggia fracture. This is a fracture and dislocation in one. So it's a fracture of the proximal 1/3 of the ulna with a concomitant anterior dislocation of the radial head. And so I encourage you guys to look that up. So they reduce the radial head and they fix the fracture through plate screws. These little lines that you see here are staples in the individual skin from to close the incision. So they show up on the x-ray. So with elbow fractures, what are the signs and symptoms? Well, like an elbow dislocation, there's a visual deformity, severe pain, swelling, gross effusion, ecchymosis, reduced range of motion in all planes, and neurovascular symptoms may be present. You want to rule out an elbow dislocation and a muscle rupture. You can see how this may go, oh, I think you tore your biceps tendon. So you want to rule that out. So you can similar presentation here. No Popeye deformity. Hook sign would be there. So that's how you rule that out. Tests and measures. There's something called the elbow extension test. Very simple test. Top right. You just see if the individual can open their elbows and get fully extended and be symmetrical. It's a very high sensitivity for ruling in fractures if they cannot extend their elbow fully compared to the opposite side after a mechanism of injury that you may suspect correlates with that. So could do tuning fork again, but really you want to do tests and measures that look for neurologic or vascular compromise as well. And then the big one is you get referred them to the ER for imaging and further workup. So what's intervention look like? Well, if you have a fracture, we need to let the bone heal. So before we see them, there's probably a cast or immobilization for 4 to 6 weeks, or until it's healed, confirmed with radiographs, and then it's a slow regaining of range, slow regaining of strength. If they have a surgery, it's usually an ORIF, which is the plate and screws, and other sort of fixation techniques. And we usually see them after about 6 weeks because they're immobilized and quiet for 4 to 6 weeks there. So the last section here is chondral injury, cartilage injury. Talk about osteoarthritis, capitellar chondromalacia, and capitellar osteochondritis dissecans, lesions, OCD lesions. So elbow osteoarthritis, or OA. It may result from numerous conditions, including trauma, rheumatoid arthritis, crystalline diseases like gout or pseudogout, and those are more on the rheumatoid side of things, to the osteoarthritis side. Infection, and of course osteoarthritis are all types of arthritis of the elbow. And so we'll focus in on OA. OA usually affects big weight-bearing joints. You think of the knee, the hip, the ankle, the spine even. And in the elbow, it's one of the least common areas for OA. But if you've had a fracture or a dislocation, you're at more risk for elbow osteoarthritis from post-traumatic reasons. So osteoarthritis of the elbow is most common in men aged 40 to 60 with history of strenuous work, throwing sports, or trauma. Here's what a normal radiograph looks like on the left, lateral view. Here's what one with osteoarthritis looks like. You can see the quote-unquote degenerative changes, meaning bone spurs and loss of joint space. Signs and symptoms are diffuse pain, loss of range of motion, may describe grating or locking in the elbow, joint swelling. Because of the swelling, may have some numbness or tingling in their hands secondary to nerve compression. They have pain with ADLs, difficulty lifting and reaching. Differential diagnosis includes things like elbow fractures, dislocations, OCD, instability, epicondyle, or synovial chondromatosis. Tests and measures, really, the main one here is plain radiographs. Get them x-rayed. You could do some instability testing or some epicondyle testing to see if they have any components of those. Interventions. Conservative care could do a corticosteroid injection for pain management. Also start doing viscosupplementation, which is an injection to try to improve synovial fluid creation in the joint. So that's a picture of that on the top right. It's a series of injections over the course of several weeks. And so very common in the knee, but can do it in the elbow as well. Physical therapy is all about pain management, restoring range of motion, improving strength, and of course returning to activity. And if they do get surgical treatment, we'll go over that in detail, but they can get an elbow replacement, and that's called total elbow arthroplasty, and it looks something like this. And so it's of course a stem and a hinge joint, and looks here. Looks like it here. Excuse me. Excuse the yawn here, guys. I usually do these lectures at night when the kids go to bed. So I've been in clinic all day. Come home and then get after it for you guys. So excuse the occasional yawn. But you can see in the picture bottom left is the staples again in the incision area. Next up is Radiocapitellar Chondromalacia. Radiocapitellar meaning the articulation between the radius and the humerus, which is the radial and capitellar surfaces, meaning the radiocapitellar joint. Okay, if you haven't heard of that term before. This is chondromalacia means softening of the cartilage or cartilage wearing, right? So this is cartilage irritation or damage to the radiocapitellar joint, usually on the capitular side. And so progression of symptoms leads to Osteochondritis Dissecans or an OCD lesion, and we'll get to what that is in a second. But repetitive valgus stress causing compressive forces in the lateral elbow in youth athletes is what causes this. So we talked about the throwing, how valgus stress causes tensile strain on the medial elbow, and the lateral elbow causes compressive forces, and that's what we're getting into here. This is signs and symptoms include lateral elbow pain, may have clicking, catching, popping, locking, swelling, tenderness, etc. So we move on. Conservative treatments. Activity modifications, number one. If this progresses and worsens, it can turn into a cartilage defect instead of just cartilage irritation. And so that's what's called an OCD lesion. You can see the compressive, circle through the area of compressive forces there, which is where this injury occurs. And if it progresses, it turns into this, Osteochondritis Dissecans. Again, adolescent athletes, throwers, gymnasts, swimmers, tennis players, athletes that stress the shear force in the lateral compartment of the elbow. the etiology of this is not really well understood. We do think there's shearing forces, but there's millions of kids who throw a lot and never get this. So what is the etiology? Well, I think there might be a focal artery injury, which leads to subsequent bone necrosis resulting from the lateral radiohumeral compressive forces. We also think maybe, I've heard one doc say they think this is the case, and one that doesn't, that treats this all the time, is if you have an attenuated UCL or your hyperlaxity individual with lax ligamentous support, maybe you're getting more gapping at the medial elbow, more compression at the lateral elbow, and leads to something like this. But that's up for debate. So, patient history, signs and symptoms: lateral elbow pain, decrease in elbow range of motion because of maybe there's loose bodies now because cartilage has been injured, and locking, catching, clicking. If we take a look at the pictures on the right, you can see that there's a defect in the capitulum or capitellum, whatever you want to call it, of the humerus, and this is pre-op and post-op. Then you have a similar picture here. This is a 3D CT scan which shows the defect better. So if it is a small and stable lesion, meaning cartilage has been impacted like this, but is stable, then they try to manage this conservatively through activity modification. If it is unstable, they can go in and debride this area. They can do bone marrow or microfracture for hope for cartilage regeneration, be fibrocartilage instead of hyaline cartilage, but cartilage then nonetheless, and then any loose body removal. So sometimes this cartilage can break off and float around in the joint. It's called a loose body. Go in and remove that because it can get stuck in the joint and alter the mechanics. If it's an unstable lesion that's large, then an Oates procedure may be the right move, which is osteochondral autograft transfer system, is what they call it. And so you transfer bone and cartilage, osteochondral autograft, from a different part of your body to this part of your body. So usually it's a non-weight bearing portion of the cartilage of the knee that gets transferred. So we go over that more in the post-op lecture. Thank you guys very much. This is the inert tissue lecture. I appreciate your time, and email me with any questions. Thank you very much.